Good afternoon. Thank you, Dr. Sudipta Mitra, for bringing in this important topic. And I'm going to talk about managing uveitic cataracts. Well, managing uveitic cataract involves a multi-pronged approach, mainly focused on controlling inflammation, meticulous surgical technique, close monitoring for complications, and with the ultimate goal of improving vision. We all know that this prolonged inflammation in uveitic eyes leads to breakdown of the blood ocular barrier, and that leads to cataract formation. And many times using steroids for a very long time may also induce cataracts. Well, we need to focus on the pre-operative management, the surgical management, and the post-operative management in these cases. As for the pre-operative management, controlling inflammation, the mainstay would be the medical therapy, and in certain situations when the etiology is infective, we need to look at antibiotics and antivirals whenever required. And for example, in HSV1 or varicella zoster virus induced uveitis, we need to give full dose of antivirals maybe 7 days prior to the planned surgery, and thereafter we continue for at least 1 week prior to surgery, and then of course in a prophylactic dose later for about 4 weeks or so after the surgery. Now we need to ensure that the eye is quiet from any inflammation for quite some time, typically 3 months or more. And we need to carefully assess these patients. The presence of corneal opacities or maybe condensations or opacities in the vitreous, CME, cystoid macular edemas or macular scarring, or if there are any optic atrophy, these may limit the visual outcome of these patients. Well, as for the surgical management, for cataract surgery, phacoemulsification with IOL implantation is the method of choice, surgery of choice. And of course, the steroid coverage, we need to look at perioperative steroid coverage, and managing the pupillary issues are also important. As for the choice of IOL, uh, it will depend on the individual factors and the surgical techniques, but in general, the consensus is hydrophobic acrylic IOLs. There are many others which are also suitable, heparin-coated IOLs and others. But it will be case-to-case basis. The surgeon has to decide. There are many situations where in GIA, in young children, uh, earlier you used to avoid implanting lenses, but then after the advent of biologicals, the situation has changed. Of course, now let us look at a video of a typical surgery. Here what I show is I use a iris repositor, a band, blunt spatula just to break the posterior synechia, as you can see. And then the pupillary membrane it needs to be peeled off, not all at a time. You need to be meticulous so that there is no hemorrhage. There will be little hemorrhage, but we need to be very meticulous and remove the whole thing. And then we need to use multiple instruments, maybe 2 instruments to stretch the pupil so that it can accommodate a pupil expansion device. Any device of choice would do. And here I am just trying to implant a BX pupil expander, and whatever is available can be used. After that, once we have adequate pupillary exposure, because it's a white cataract, I am using little trypan glue to stain the capsule, and it's done under viscoelastic. You can see there is enough staining, and so we can proceed with a Rexis as usual. We need to remember in these cases the size should be adequate. So because uveitic cataracts, these patients are prone to developing capsular phimosis. The Rexis becomes small later on because of repeated inflammations. And the other procedures are similar. This is a soft cataract. So what we do here is, we do a quick phacoemulsification. It's a soft cataract, comes in flakes. What we need to remember is removing all pieces very meticulously, and we need to take out all the cortex as much as possible. We need to take special care to take out all the cortex. We don't want to leave anything behind, especially in these situations. And then uh, we implant a lens. In this case, a hydrophobic acrylic lens is being implanted. Once it's implanted, we make sure that it's definitely in the bag, and uh, then we take out the pupil expansion device so that once it is taken out carefully, we take out all the viscoelastics from behind the IOL as well as from the AC. We need to be very meticulous in cleaning up all the viscoelastics, because again, all these factors will lead to recurrence of these uveitis. Now, post-operatively, the steroids and cycloplegics would be the mainstay. We need to closely monitor these patients uh, for further recurrences and complications, and aggressive treatment for complications is very important. The key considerations here would be patient education, and we need to make people understand that you need a certain amount of expertise, surgical expertise, that is involved in doing these cases, and of course, uh, these will result with patient cooperation. Thank you.
Thank you, Dr. Ghosh. I would request our panelist, the expert from inflammation, Dr. Parthopratim, to start the discussion, and the audience also can join.
Excellent case, Siddhartha. I think it's most important to understand that the main cataract surgery all of us we can do. The most important in uveitic cataract is how is your pre-op inflammation control and how you can control the post-op inflammations. Two quick points I just want to highlight. The two cases you have to be very careful, even if the patient is quiet for last 3 months also. One is HLA-B27, another is VKH. These are the two cases. If the patient is not on any kind of immunosuppression and the eye is quiet for even for 6 months also, be aware that you need to start some oral steroid, at least wait for 1 month before you go for cataract surgery, because these two entities are known to throw very bad inflammation after cataract surgery. Sometimes it can clog your entire visual axis and result into fibrin formation, membrane formation over the IOL. So it's always better to take care of that. Two warning signs for before you operate a case of uveitis is one indication is that if the patient is having extensive synechia, and the second is if there is a history of cystoid macular edema in the past. So these are the cases you have to be very careful. And sometimes if there is a history of cystoid macular edema, it's important if there is no contraindication, IOP, or patient is not a steroid responder, you may have to inject a Ozurdex also to reach the desired level.
Great, thank you. Dr. Amitabh, your viewpoint, he's an inflammation expert from Kolkata. Microphone, please.
Mike.
In the meantime, Dr. Partho, you said about steroids in the preoperative period. What is the period, how many days before and for how many days? The oral steroid?
Yeah, it's always better that two condition, a VKH and HLA-B27. It's better to do a oral steroid for a little longer time if the patient is not on any kind of immune suppression, because if there is extensive synechia and all, and 3-4 days of steroid may not help in such conditions.
So you prefer a month?
Yeah, it's
Okay.
a month.
Okay, Dr. Amitabh.
So the baseline for any cataract surgery in uveitis is the eye has to be absolutely quiet. There's no compromise on that. If there's a flare, it's fine. You can still go ahead with surgery, but there should be no cells in the anterior chamber, or there should be no active inflammation, as Dr. Partha said. And there will be a couple of per-operative challenges, which Dr. Siddhartha Ghosh has covered very well. In my hands, I've found the pupil expanders, the Greishhaber hooks, to be the best because they cause the least amount of damage. I don't really like using the Kuglins hooks, or I'm not pretty sure I haven't used the Bhattacharya or the Malhugen rings, but it does not take a long time. It's just that you have to make four side ports which are extra. You can use the 15-degree blade itself to make it. And the other thing is the intraocular lens should be in the bag. And I think the lens of choice is hydrophobic acrylic IOLs. And post-operatively, you have to put the patients on steroids in a tapering dose. You might need, many of these patients might need non-steroidal anti-inflammatory drops as well, especially if they have had cystoid macular edema in the past. And the most important thing is to counsel the patient, because you have to give them realistic expectations, because if they have spent money, they might want a vision as good as a normal cataract surgery, which may not be possible all the time. Thank you.
That's great. So any questions from the audience? Yes? Quick. And I would request Dr. Ayan Mohanto, the next speaker.
Partho,
Partho has something?
you said,
On your-
as Siddhartha also mentioned, that it should be ideally 3 months we need to wait. But many a case, practically what we see, the inflammation is not taken care, the cataract is increasing. There is bilateral cataract. In those cases, would you advise to do a cataract along with Ozurdex implant?
Certain cases, see, doesn't require any steroid. For example, Fuchs uveitis, no need to go for that. VKH patient, yeah, sometimes you can combine it with this Ozurdex also, but the only problem with that is VKH is a multi-system disease. So if there is some recurrence of inflammation, you have to control it, all these things, because so many organs are involved. So that is important, number one. And yes, Ozurdex can take care of that, but sometimes you don't know whether these patients are steroid responder or not, because suddenly they have come to your hospital and consulting you, you don't have a proper documentation, and injecting something which you cannot take back. I think it will be, you have to be a little careful that directly injecting going for a Ozurdex.
Thank you. Dr. Anil Mondal, our
An
expert.
important consideration in the preoperative evaluation should be, is there any associated glaucoma? Most of the cases will have some rise in intraocular pressure. Proper evaluation should be done, and in borderline situation, probably if the patient is very well controlled with 1 to 2 medication, probably simple cataract operation should be okay. If the patient requires more than 2 medication along with systemic anti-glaucoma medication in the form of systemic carbonic anhydrase inhibitor, probably you'll have to decide for triple procedure versus simple cataract. As has been told, very rightly emphasized, lens should be in the bag. The type of cataract operation, phacoemulsification versus any other surgery. I do not think that phacoemulsification is the only way to go. In a difficult situation like this, probably one can go ahead with manual small incision cataract extraction. No problem. The outcome may be, in the early phase may be little different, but in the long run it doesn't matter. And in the post-operative evaluation again, the inflammation control, the level of intraocular pressure should be controlled, and all these things should be preoperatively discussed with the patient what should be the realistic outcome in an individual case.
Thank you. Thank you. So we have our next speaker, Dr. Anmant. You want to say? Okay, Dr.
Just
Subhadra.
one point that you can have uveitis cataract with hypotony. These are very difficult situations because you need to really do a UBM to know why this hypotony is there. Because if there is ciliary membrane and you inject Ozurdex, then you've created disaster. So you can't just take a cataract and say, so I've seen, giant retinal tear where the whole retina is folded up on the disc and you didn't realize there's a RD behind because it was a stickler with cataract and uveitis, and so the other eye could give the clue. So I think more than, of course, controlling the inflammation, the proper diagnosis, pre-op, even if that takes 1 or 2 visits. We have seen oculesmic syndrome, masquerading as a uveitis cataract. So if in an elderly you see some cells, then you should think what's the etiology. Just giving steroid and treating that cataract is not enough. You may have to do ARC before the surgery because they can have very subtle NVI or NVA. So I'm just saying that proper evaluation of history, evaluation, and taking your time. There's no emergency. Taking your time to think through that case. They are very difficult cases, challenging cases. Sometimes you have to do cataract surgery with silicone oil injection to counter that hypotony. So I think, taking help of your retina colleagues, because I'm from retina side, and discussing the case makes a huge difference.
Thank you. Thank you, Dr. Subhadra Jalali. So, see, there are a lot of inputs, you just can't be a run-of-the-mill surgery. You can't be dictated by the patient, sir, karna hoga, kar do. Nahi hoga. You have